So should I start? Yes. Thank you, sir. Thank you very much. And I am very much, although I am on the presentation mode, but later I will talk to you a bit. Actually, it is a great pleasure to be here to deliver some evidence-based information that I have gathered around 2 decades, choosing Bangladesh rural aspect as a role model, and which can be replicated to many other countries in the world. And if I talk to my a little bit about my career, actually I was born in Bangladesh, and just after my graduation, I was invited by Japanese government to come here and to pursue my PhD here. So I got my PhD in cardiology in 2003. And my professional life started here in Japan. And I have been working here for 28 years. And mainly, I have been supervising Japanese medical doctors who are pursuing PhD. And also, I am involved with all types of researches, like from cell level to the global health. And so it's a great experience, what I can say, opportunity to be exposed both to the developed and developing countries in perspective of the healthcare, and to realize the differences that, for example, when we developed a drug for a cancer that developing countries people cannot afford. Okay. So my whole research career has been dedicated to find out something which is affordable and which can be used anywhere of the world with a low cost. And I'll later talk to you a bit about my recent research on bone cancer, how your garden plant can kill the cancer cells. Okay, so with your permission, I am going to start the presentation. Actually, Although I have been detached from Bangladesh for a long time, but I was there. Every year I went 3 to 4 times to Bangladesh, and I have been working with the Nobel laureate Professor Muhammad Yunus. I was his right hand for the health perspective, for the health issues, for the South Asian people. And but I realized that without establishing the evidence-based healthcare practice and medicine, we cannot do anything. Later, I started to think about to develop a research center called Health and Disease Research Center for Rural Peoples in Bangladesh, abbreviated as HDR-CRP, which started its journey since 2006. And here we are doing all the works volunteer. Okay. We don't have funding or even project, because as I stay in Japan, it's very difficult for me to manage international money for any type of works where I am not present physically. Okay. So the HDR-CRP has the dedication to strengthen the evidence-based medicine in Bangladesh with established team of national and international medical and healthcare research scientists and academicians. Here is my brief, very introduction. And here is my email address is written. If someone wants to contact me, please contact. Okay, so I have been given many recognitions, like doctorate degree I have given 3 times. But here you can see a name that the Nobel laureate Professor Muhammad Yunus, who is the Nobel Peace Prize winner in 2006, because of his microcredit innovation in Bangladesh. Later, this model has been replicated to many other countries. So I will talk something that is written in the slides, and also just a free conversation so that you understand, because there are some technical terms here, but you don't need to understand that, because the main concept I want to give you today, and the picture is shocking. That result I have been given to the global health agenda many times. Okay. Here you can see that this is the HDR-CRP. It is Bangladesh Health Ministry registered, and also NGO Boru registered a volunteer organization. And here you can see Professor Muhammad Yunus. I have been with him in United States many times, and we have been delivering the speech how to improve the women health for South Asia. So you can see here the laboratory. Here is the village work, and also here the national level, international level work at the United States. So I have been going through all the processes. So our long-term goal is to remove the poverty. That Professor Muhammad Yunus also think that we have to come out from the poverty. And once we eradicate our poverty, then we can get our good health and well-being, and we can be more productive about in our lives. And of course, women is a majority part of the world. And I have seen many women in very hard to reach area in Bangladesh who have never even measured blood pressure in their lifetime. So my focus was to the rural women, hard to reach rural women. Here are a lot of international organizations whom I have been collaborating, a list of places, and this is my career a bit. I don't want to go in details. Just I want to say that I am a scientist also, because I have been teaching students. I have been also doing my research. So to date, I have been published more than 350 papers in the international journals. And here you can see also that I have been awarded the 100 Women Award in South Asia more than 3 times. But other award list I cannot show within this short time. Okay. So now what is the issue? If we look back at 10 years or 15 years before, there we can see that diarrhea, pneumonia, and then also polio, there are so many infectious diseases. But now, not so many. Here you can see so high rising of the diabetes, hypertension, cancer, obesity. So this is collectively called a non-communicable disease. That is not that those are not infectious. Okay. So my main focus was to how to reduce this double burden of the non-communicable and communicable disease, because non-communicable disease, diabetes, there is only you have to change the lifestyle. This is your lifelong partner. You cannot remove it from you unless you change your lifestyle. So probably you will also heard you will heard about the metabolic syndrome. Okay. A slide is not moving, sir. Okay, so then, sir, I will come back to the stop sharing here. Why the slide is not moving? Can you see here, sir? Slide. Okay, entire this entire, and then I have to go to the. Okay, sir, I will be back. Please teach me. How should I do it, sir? I am in the now in the. Sir, I should go to the present now here, or from where should I start? Can you teach me, please? Yes, sir. I go to the Chrome tab, right? Okay, enter screen, sir. I understand. Yes. Yes, sir. I did it. Okay, but sir, slide. I should go to the PowerPoint part, right? Okay, sir. I understand. Okay, I understand. So now you can see the slide, sir. And my slide is also moving. You can see it. Okay. Thank you, sir. Thank you, sir. So, I did not speak so much, but I would just like to show you that I am a person.
Slides are coming, ma'am. Slides are coming.
Okay. So I have started the work in the laboratory and also at the village level. Then I also attended the global health policy making conference in United States with Professor Muhammad Yunus, who is the Nobel laureate, Peace Prize winner in 2006. Am I audible? And can you see my slides, sir? Yes, okay. Okay, sir. Thank you. Okay. So what I usually intend to do is that only by poverty reduction, we can achieve our health, we can achieve well-being, we can make the women more productive in their life. So I have been collaborating with many international organizations. Here you can see also here. And this is my educational qualification in brief. I don't want to go in details. But what I want to show you here that while I have been working with hard to reach women at the rural level, at the same time, I have been publishing all the findings that generated the evidence-based database for the South Asian countries. I did analysis for Asian countries, ASEAN, Asian countries, where I can find similarities for the many risk factors for the chronic disease, that now we don't say more about the non-communicable disease. Of course, COVID was a big issue, but we talk about diabetes, we talk about cancer, we talk about chronic lung disease, we talk about hypertension, we talk about stroke. And these are the lifetime friends. Only by changing your lifestyle, you can prevent these diseases. So we don't believe in any medication. We want you to change your lifestyle and to reduce the expenditure for the healthcare. And the money you save, you come for the society and you help in the poverty reduction. So here is the slide. You can see that I have been awarded many times, more than 223 times for the peace, for the scientific contribution, for the healthcare research, for the women health research, for the peace, for the humanity. So there are different categories award I have received to date. Probably you may know the name metabolic syndrome. It's just like an epidemic that previously it was cholera, chicken pox, smallpox, many things. So this metabolic syndrome is just like epidemic right now, pandemic. It's like a pandemic, okay, which predisposes you to develop the heart disease, diabetic, strokes, and many other things like cancer also included. Although I cannot say the detailed mechanism in this short presentation, but we dissect the mechanism and we start from the genetic level and we believe in the prevention process, preventive medicine, as well as the lifestyle medicine, as well as the natural medicine, as well as the holistic approach of health and well-being. So here you can see blood glucose, HDL. You always say cholesterol, oh, it is not good for health. But there is one cholesterol that is called HDL, which is really protective for your heart, your body, your diabetes. And you will be surprised to see what evidence I have generated. I am coming later, okay? And then waist circumference, obesity is a big issue, blood pressure, also triglyceride, a silent killer. So here you can see that if we compare the data here, okay, this is the low and medium income countries, and this is high income countries. This is the communicable disease, That means infectious disease. In very easy term, infectious disease. Okay. So in low and middle income countries, interestingly, by 2030, this infectious disease is going down fast. But the blue part, that is called diabetes, hypertension, stroke, heart disease, are getting higher. But here you can see in high income countries, the picture is not so changed drastically. So we are poor. We are from the middle class. But why a disease like diabetes, heart disease, that we generally believe these are the diseases of the rich people, people with a sedentary lifestyle, are so highly prevalent in low and middle income countries? That was my main research hypothesis. And today I will be able to show you some data that will make you thinking that no, there is something wrong in the hypothesis or in the conception that we believe right now. So this we call lifestyle related disorders. Okay. By changing lifestyle, you can be fine. These are the diseases. We have no interest for the non-communicable disease so much, because if you once become diabetes, how much money will you spend to the healthcare? If you have hypertension, if you have heart disease, what would be the cost? Because this disease is for lifelong. So let's start changing from the lifestyle. Okay. And I will show you some evidence today. So I have been doing the nationwide investigation in Bangladesh for last 15 years with using this huge amount of subject. And my target is Bangladeshi rural women, not urban. We have started this work in 2007. We are generating our database gradually. So you will be surprised to see here that if you see the metabolic syndrome is a cluster of syndrome. These 5 components, if you have waist circumference, high triglyceride, low HDL cholesterol, never think cholesterol is bad. There is a good cholesterol, and that is the key of your body. High blood pressure, high fasting blood glucose level. So these are the 5 criteria. Among these 5 criteria, if you have 3, then we call it metabolic syndrome. And you can see that even at this mid-age, 40. Okay, so let's come to the next slide. Okay, slide is not. Again, I am stuck. Okay. No, okay. So I come back. So, sir, here you can see that I don't want to show you so much. Just look at here. About 85% of the rural women in Bangladesh who don't have the sedentary lifestyle, they have low HDL. Low HDL means this is good cholesterol for your body, which protect your heart, which prevents diabetes, which prevents stroke. 85% of the rural women. This is unbelievable picture. And through our last 15, 16 years, nationwide investigation, we have found this. They never eat any burger or KFC or McDonald's or anything. They are very hardworking housewives. They work hard. But why this is? Here you also can look that if we combine that hypertension with high triglyceride and low HDL, again rural women, this high proportion compared to men. If we come to the hypertension, that means high blood pressure, with high blood glucose and low HDL, again women is high. If we talk about high blood pressure with high blood glucose and the obesity, then again women group has the high prevalence. Then I want to come to another factor about the premenopause and postmenopausal women. You know that women, we believe that when they lost their menstruation, they became non-productive and they cannot work anymore or something. Yes, when the hormone is going, female hormone is going from their body, their menstruation is stopped, they are going to the menopausal state. You can see the diabetes picture. Before menopause, after menopause. Before menopause, after menopause. Before menopause, after menopause. So these are the picture. I don't want to show it this slide because this is a little bit complicated story. So let's have a lesson from this presentation that low HDL seems to be the commonest component of the metabolic syndrome, that means chronic disease that called diabetes, cancer, heart disease, hypertension in rural women. And the same situation is in India because I have also investigated a lot in India, also in Nepal, also in Sri Lanka, also in Pakistan. So now, but these women are apparently healthy, but they are developing heart disease, diabetes gradually, and they die without diagnosis. What we should do at this moment? Okay, so we need to think, rethink that what should the policymakers should do. Another thing I will tell about that. This is very advanced level of research. Okay. There is a molecule called VEGF. If it goes down to your body with age, that means you are susceptible to develop diabetes. That slide I will show you also. This is not the slide. Okay, I am coming with the slide. Okay, before that, I want to show this slide. So this is the clustering of the health risk behavior. Okay, you can see that like smoking, physical less activity, alcohol, it's not so common, and less intake of fruits and vegetables, high blood pressure, then high triglyceride, low HDL, then high blood pressure, high glucose. So if I say that these are the clusters, okay. So in men and women, if we see that these health risk factors, more than three, it is almost equal or a bit high in the women. You can see here. More than 3 health risk factors. And more than 4 also, it is almost the same. And more than 5 health risk factor, it is almost the same. But when it comes more than 6 health risk factor accumulation, then women goes double than the men. Nobody knows these results. This is our analysis. This is the clustering of the health risk behaviors. Okay. So this is just, if you have one health risk behavior, one health risk factor, 2 health risk factor, this is men, women, 3 health risk factor, 4 health risk factor, 5 health risk factor, more than 6 health risk factor. You can see this picture. So we have analyzed many countries like Bangladesh, India, Nepal, Sri Lanka, Bhutan, Maldives, Pakistan. And here you can see that low HDL, this is very, very prevalent factor for the South Asian countries, this low HDL. And this is the only reason there's the development of diabetes, hypertension, heart disease, stroke, cancer, chronic lung disease. So we have to improve this HDL level. So now our question was that Bangladesh rural women lack urbanization. They don't have the fast food. They don't have high socioeconomic status. Then why there are so many health risk factors, especially related to the chronic disease, not infectious disease? After that, we went to the genetic analysis, whole genome analysis. And we found that genetic factor is the main contributor for this hidden health issue for South Asian population. Here you see that this is also the physical inactivity. You can see in Bangladesh women, more than 52% women have less physical activity. Also India the same. Pakistan a bit more higher. And Bhutan also the same. Afghanistan almost the same. Maldives also the same. So this HDL has very close relationship with the physical activity. Then the next slide, I'll show you some results. So you see the prevalence of low HDL cholesterol, again good cholesterol. Bangladesh, rural women, 84%, 85% women, this HDL level is low. In India, 72.3%, Pakistan, 73%, Sri Lanka, Nepal, 70%, and Afghanistan, these countries. But Bangladesh, India, Pakistan, Nepal are almost the same. But if you compare in United States, where people are so obese, they have heart disease, they have diabetes, and it is written always in the journal. You compare with Bangladesh and United States, Australia, Norway, New Zealand, Ireland, Canada. You can see the picture. Why people die suddenly? Why this the premature death? For why is this silent killing? We don't know. So we have to address this issue soon. Each human life has own impact. When a mother at the age 40 dies, even she is rural woman in a family, what are the after consequences? We have to think about. We just say United States diabetes is growing so fast, but low HDL is the main factor for the developing diabetes. This is regional difference. This is genetic difference. This is subcontinental difference. We don't know. But this is the evidence I have been showing you today. So then here you can see again another picture that for this Bangladesh also. Female low HDL is higher than the male. This is irrespective of urban or rural. This is whole Bangladesh. So male are more protected than female. And this is for the rural and urban 71% and 66%. That means women group are mostly affected. Okay, because you know that these urban women, they are so luxurious in their lifestyle. But the HDL situation is almost the same. Then we started to think about how to improve this low HDL level in the rural women in Bangladesh. Then I have designed an exercise plan that every day they will walk 1.5 kilometer each time, total 3 kilometer twice daily, and this should be supervised walking. That means someone will mentor them and then see whether their HDL level is improved or not. Here you can see the picture. This is the Bangladeshi rural women. As they are coming outside, they are wearing a little bit good dress, but the real picture is not like that. So here you can see, just after 6 weeks of walking, mild walking, you don't have to walk so fast. Just after 6 weeks of walking, every day 3 kilometer, 1.5 kilometer in the morning, 1.5 kilometer in the evening. This is the statistical value. The before exercise, after exercise, the HDL level is significantly increased. This is just for 6 weeks. We wanted to do a piloting. And also same time, of course, if you do exercise, your body weight will be reduced. You know all these things, but our main concern is about the prevention of diabetes, chronic disease through the modulation of HDL. We want to improve your HDL level. And we want to decrease your LDL level. That is the culprit. So from this exercise, and here you can see the 10 weeks of exercise effect, that After exercise, the HDL level, that means good cholesterol, is significantly improved in the rural women in Bangladesh. So our conclusion, physical inactivity is a big issue in Bangladesh in recent days, and the current research findings show that even a 6-week mild exercise program, daily walking, improves low HDL level in Bangladeshi population, which can be a potential and promising strategy for the prevention of non-communicable diseases in Bangladesh. Okay, so this is for diabetes. I have designed another study plan because many Bangladeshi women die at the pre-diabetic stage. Even they don't develop the diabetes at that time. So we started again this walking program, and we found that this is the baseline, that before starting the exercise, the fasting blood glucose. Okay. And just after few weeks of exercise, the blood glucose reduced to such a level. So interventions need to increase physical activity at the population level are effective and must be integrated into strategies to prevent and control non-communicable disease. That is your friend, lifelong friend. Mass media interventions can be considered a best buy for physical activity promotion. Multiple intervention strategies, including physical activity, have been shown to have favorable cost effectiveness profiles. And there is an emerging body of evidence which show promise of cost effectiveness for physical activity intervention alone. However, these have not been assessed for the global application. A multi-level application and evidence generation from this proposed model is essential. A large-scale evidences can only transform this proposed model to establish as a vital public health policy to prevent and combat non-communicable disease. And there are a lot of things to talk, but time is very limited, so I'll not go in details for that. Another thing, just I'll show some slides about the postmenopausal women, that how we can protect them. Because women at the age menopause, they are highly susceptible, they have the more risk to develop diabetes, stroke, and also Alzheimer's disease, because they have already hidden health risk factor. Again, this post-menopause imposes additional risk to their health. So this is a very big picture that findings should be patented soon. Here, I would like to introduce you one thing, that this is very advanced level of research. Here, there is one molecule. This is called VEGF. We found that if the VEGF level is going to low, then you have the more probability and susceptibility to develop diabetes. Until now, we only say Okay, if you become fat, there is a probability for diabetes. If you have high pressure, there is a probability of developing diabetes. But I already showed you how low HDL works and how we can improve it. The second one, this is called biomarker. Okay. It is very easy to measure. If you just measure the VEGF level in your body, they can predict that within how many years you are going to be at the pre-diabetic stage, at the established diabetes stage, at the advanced stage of diabetes, at the diabetic stage with a lot of organ complications. A large cohort study is going on and it will be published soon. So another important thing I wanted to address in Bangladesh, of course, as a representative for the South Asian countries, pregnant women. That is called GDM, gestational diabetes mellitus. Very few people know about it. We have done a nationwide survey and we found that less than 5% women know that during their pregnancy, they can be affected by diabetes, which cause a great consequences both for the mother and the baby. So then I applied to World Diabetes Foundation and they gave me some project money and I screened 45,000 rural women in Bangladesh who are pregnant. And I found that in rural area, about 11% pregnant women have diabetes, but no one knows. Here we did a lot of advocacies, a lot of programs through the countrywide educational program, awareness program, many things. And we published it also in the newspaper. So this GDM, gestational diabetes mellitus, in Bangladesh, this is in Bangladesh. Same situation also in India. It is growing up with age. Women say, why women cannot have child even at the late age? Yes, many people say that for the women empowerment, but the science is different. Evidence from the medical research is different. It's just a slogan for the women empowerment. Who will take care of the baby who have been born with disability? So as a healthcare scientist, as a physician, we always recommend to have the baby at the early age. So you find this picture here. This is the age. When a woman is more than 35 years and pregnant, they have the probability, they have the prevalence of diabetes about 28% in pregnancy. So there are a lot of factors we have measured in Bangladesh and also other countries. And here you can see another shocking picture. We say that rich women only can have diabetes. No, poor women, they don't have diabetes. No. This is ultra poor population. And this is the solvent woman. This is ultra poor woman. You can see the picture. In the pregnancy, 71% of these ultra poor women developed diabetes in Bangladesh, whereas solvent people have only 28%. This is the sub-analysis, stratified level of analysis. In the real picture, in the broad picture, you cannot see it. But when you dissect it, then you can understand. So we did a lot of awareness program in Bangladesh with the government, also with many NGOs, and also how to improve the antenatal care, how we can include the blood glucose checking as a mandatory checkup for the pregnant women in very hard to reach rural area in Bangladesh. Still now we are working for that. We want to educate medical doctors. We want to educate the community health workers. We want to educate all level of people, because health is your right, basic right. And by 2030, we are promised that we achieve universal health. So here you can see that we are doing a lot of works everywhere in Bangladesh. And we have also established many diabetes screening center for the rural pregnant women in Bangladesh. And also we made a lot of banners, also poster, and we just paste it to the trees and also shops and many, many places to raise the awareness. Okay. Here, the national level conference, I have been talking with the health minister in Bangladesh next to him, and we have been talking how we can improve the situation. Okay. And we also in newspaper we have published a lot. We have been speaking. I fly from Japan and speak and work with them. And another C, this is a bridging. This is communicable disease, infectious disease. This is non-communicable disease, you can say diabetes. You see that how this is interconnected, how the double burden is now imposed to the global level. This is the tuberculosis patient, women, men, 33% tuberculosis patient in Bangladesh, women have diabetes. So there is a cross link. Tuberculosis, this is infectious disease. This is caused by bacteria. And non-communicable disease, diabetes, this is lifestyle. But there is a interaction. Here in this slide, in the bar graph, you can see it. And also another very shocking picture. Arsenic is a great environmental poison for Bangladesh. In many areas, arsenic in the water has devastating impact on public health. You can see here, again the women group who have the arsenic impact in their health. Also diabetes is there. So what does it mean that? Environmental factor is also a great contributor to the development of chronic disease like diabetes. And then also for the COVID, as we work for the women empowerment, so also for the COVID, we work, even there is the life risk there. Okay. And you can see that again, compared to male, female group are much more affected by COVID in rural Bangladesh. This is the prevalence, means percentage of the COVID-19 positive patient based on gender. This is female, this is male. And then we started to strive how we can improve the vaccination status for them. And we have a bit success that we could make women group a bit more vaccinated than the male group. This is the result from our hard efforts with a dedicated team who work for the people. So here you can see that I invited Professor Muhammad Yunus, who is the Nobel Peace Winner 2006 for the microcredit in Bangladesh. Here I am representing Bangladesh, and he is Japanese. He is a health minister in Japan. Okay. So we are exchanging. This is flag for Japan, this is flag for Bangladesh. And here, my previous workplace, this is Professor Muhammad Yunus. I am here and all are the Japanese staff. Okay. So we have to go for the SDG achievement, sustainable development goals achievement in terms of health through the poverty reduction. And as a woman, of course, I feel for the women and for all humanity. Thank you. Thank you for your passion. Okay, thank you. Sorry, sir, for getting a lot of time because this is vast work. I cannot explain you in 30 minutes. Okay, thank you. Yes, thank you, sir. Thank you for inviting.
Good evening, Dr. Bedkar, sir, Principal, sir. Good evening, ma'am. Wonderful presentation you have made. I'm a professor of community medicine, and I can understand better, how to collect data and where to collect data and how to, do a lot of work in field work is required. And after collection of the data, we have to convert it into information and the intelligence we are getting. So wonderfully placed all these facts and very extensive work you have done, definitely. And yes, definitely when we are talking about the global aspects and the local aspects, there is always a difference between these. And we are talking about the Asian countries. Many of the times, you'll find the communicable diseases and non-communicable diseases. When we are talking about communicable diseases, you'll find the burden has reduced in Western countries, but you'll find we are still carrying that burden. And plus to that, we are added our non-communicable diseases also. So we are fighting with the two group of diseases, communicable and non-communicable. And especially when we are talking about rural and tribal areas, yes, definitely the communicable diseases are still prevalent, very much prevalent. And about the non-communicable diseases, they are having multiple risk factors. We cannot identify a single risk factors. I think when we are doing individualized studies, then we have to find out which risk factor is more dominating, and then we have to control that at a particular level. As I'm a physician, yes, definitely we have to do all these things. And you very well placed that there are multiple reasons and risk factors, modifiable, non-modifiable risk factors you have talked about, and non-modifiable genetics, what you are talking about. But again, a question comes, from where this genetics, because we people are working so hard in the field, and we don't have much sedentary job in a rural area, at least, or tribal areas. We try to, get that kind of a lifestyle of Western people, but still, we are having the jobs, the work, whatever the trades we are doing, they are traditional, and we are dealing with those things. So genetics a big question. How, from your data, it has been reflected that the genetics are playing a role. So that is one of the very important thing what we have to think about, and how that genetics has originated. We can say that one parent or two parents were having diabetes, and that is why the next generation is getting diabetes. But why these two people got the diabetes? That is again a big question when we try to dig it out. And no doubt, what I feel, the risk factors while talking about the globalization, right? So globalization has taken place, and we have lost our own identity and the living standards and the lifestyles. And nowadays, because of the globalizations, we are having fast food, junk food in our diet. And what the person is eating at California is also eating at, in our places. So same food they are enjoying. So the thinking and the behavior pattern has changed. It is not just a lifestyle, but the behavior pattern also changed. And even we are talking about the rural ladies, and they are housewives many of the times in Asian countries. But still, you'll find they are lost the typical work they used to do. Now they are having television in front of them. They are having mobile in their hands, and definitely it has a great impact. And very well you have placed about the arsenic album also. I remembered one of the the documentary I was going through, and where living on age in one of the national channel of India, and I found that the people were getting all ulcerations and weakness and tremendous complaints all of a sudden, and they started searching out, and they found that the nearby factory, they were dumping their waste into the ground, and that has percolated to the groundwater, and people were using that hand pump water, and they received that. Yeah, am I audible?
Yes, sir. Yes, absolutely, absolutely, absolutely.
Yeah, so here you'll find very important thing, arsenic you have mentioned, and I remember that story coverage on the channel. And then you have discussed about very important thing. You have discussed about very important thing, that is about the HDL level. The cholesterol, when we are saying the cholesterol and lipid profile, when we are saying the cholesterol tops one, then comes triglycerides, then comes HDL, LDL, and HDL. All these other components are adverse. If their concentration increases in the blood, it has impact. But a good amount of HDL reduces the risk of cardiovascular diseases. So very well placed that HDL level we have to think about. Many of the people are concerned much about cholesterol level, but I think we should be concerned about the HDL level. That is what is a learning for me today. And definitely the exercise is there. And many of the people, they are thinking that doing hard work, exercise, they can increase. But I think a small step toward health is also much required. Even you are going with a walk, not fast walk, but at least you start walking and the things will start improving in your health. So wonderfully blessed, presentation. You have talked about pollution also, the soil pollution, water pollution. And I think it is a very important descriptive study what you have done. And it requires a lot of efforts. I can understand very well. We have done some kind of experimentations like this on the community based because I'm a professor of community medicine. So usually we are getting involved such a kind of activities. So taking sample and taking, cross-sectional studies or longitudinal studies are very important in this case. So wonderfully blessed, but the interventions are also you have worked out. It is not just you have worked out about the various elements, that risk factors that produces this condition, but you have talked about the interventions also, the walking at the diet pattern, reducing the pollution, going back to, our living standards, that a small village pattern and where you'll find plenty of air, plenty of trees, and then we are having a small lifestyle, not the big cities where we are standing on a signal with a smoke, so number of things are there we have to understand. So definitely wonderfully placed, ma'am. Ma'am, what you feel about that genetic factors, in India or in Bangladesh or at other places, like Bhutan, how these people, they really develop these non-communicable diseases. What you think, no doubt the data reflect it, but what must be the hypothesis for this, what you can consider? Thank you. Otherwise, your presentation and extensive work is really very, very appreciable. Thank you.
Thank you, sir. Thank you. Actually, for dissecting this, I have taken more than 1,000 people's whole blood for the DNA collection in Japan. Okay, and now we are on the way to do the DNA sequencing as well as the whole genome analysis and also RNA sequencing in our laboratory. And I think within a year or so, we'll be able to find something at least. We are not stopped here. Okay.
So then the research, always gives a question, another question, and then we have to go to another thing. Yeah, wonderful. So I think we'll be in touch, and we would like to be here, hear from your side that what are the reasons, how the Asian population develop these genes, where is this disease conditions, hypertension and diabetes. So thank you very much. Thank you, Bedkar sir, for wonderful resource person we got today. Thank you.
You are very welcome, sir. Thank you. Thank you.
Very good evening, Betka Sahab. Assalamu alaikum, Subrina.
Wa alaikum assalam wa rahmatullahi wa barakatuh. Yes, sir.
It was very comprehensive, elaborate, and very informative. Despite you have delivered for the rural woman, but it is equally applicable to men also. Most of the components which you have described in detail, really we should take care of those, especially the cholesterol, hypertension. This is common phenomena in subcontinent, especially in subcontinent. And most of the deaths are occurring because of the cardiac, arrest, other hypertension. Diabetic is the hub of in India, it's very, very dangerous in youngsters in India between 20 and 35 are suffering from diabetics, that type 2. And this all because of unhealthy practice, as rightly mentioned in your presentation. I really appreciate and I congratulate you for wonderful efforts you have put in sincerely and having won so many laurels, and also the number of publications really is astonishing for anybody having. I think you are also a housewife and also doing this research. It's wonderful. You are an example. You are a living legend of this Asian country. I'm congratulating you, madam, from the personal side and and also congratulate Professor Bedkar Sahab for bringing you on this platform. Make aware as to how we should lead our life. What should our lifestyle? Thank you so much, madam. And I don't have any questions because you made it so simple as sir rightly mentioned what to do, what not to do to have a good healthy life. Thank you so much, and God bless you.
Yes, thank you, thank you, thank you very much. Thank you.
नमस्ते जस्मिन मैडम। मैडम पहले तो आपको ढेरों बधाइयाँ, शुभकामनाएं, क्योंकि आपने विश्व स्तर पर आपको 223 अवार्ड से सम्मानित किया गया है। और मेरा एक सवाल है, दिल का दौरा जब पड़ता है व्यक्ति की, ये आखिरी स्टेज होती है, आखिरी स्थिति होती है, ये बीमारी कितने पहले शुरू हो जाती है?
Sir, can you translate me? Someone says translate. Thank you. Yes. Yes. Yes, of course, any sorry, you can translate him later. Okay. So of course, any disease comes with various types of symptoms. It differs from person to person. And also sometimes intra-individual variation is also factor. Okay. So I see many people who may have developed heart disease long time before. They just died suddenly. Okay. And we don't know the reason that why she died. Okay, because no one will bring the ECG machine to the village level to do her ECG, or no one will take the responsibility to come to her to bring her to the hospitals. Okay, so this is very common picture I have seen working with the rural population in Bangladesh. But for the urban people, for the heart disease, sometimes it comes from the pain, from the central chest pain, or for pain start from the arm or something, or sometimes just hidden, nothing. You are just feeling discomfort. You have some respiratory problem, and when you go to the hospital, you are diagnosed. So the picture is completely different from rural to urban, very different. Okay. Yes.
Okay, thank you so much. Yes.
Thank you. Thank you.
Okay,
Thank
you
you.
so
Yes.
much.
Yes. 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 Yes.
It was wonderful one. I believe in preventive medicine.
Oh, okay.
The way you explained everything, and your researches, but even your dedication going to those rural areas, collecting data, arrange them, I'm so much challenged. I think I will likely go your path. So,
Thank
but
you.
wonderful. The presentation was very wonderful. God
Thank
bless
you.
you.
Thank you. Thank you. Thank you. We have to always think about the affordable technology that the poor people can afford. And now I am working on the moringa. Soon you will be very surprised to look at how moringa kills your cancer cells. That will be coming soon. That patent will come soon. Yes. Yes.
Madam, could you share your mail ID or your contact number so that in the future
Yes, yes.
I will be grateful to you.
Yes, I will just put. Here is maybe that. Okay, sir. Please, sir. Please. Okay. I'll talk next about the cancer because it's in your garden. It's in your garden. I am working on the moringa for last 4 years. Drumstick, moringa. Every Indian home has in their home the garden. So next time I'll talk about the cancer. Okay. Thank you, sir. Thank you.
Madam, please share your email ID.
Sir, may I leave now?
Madam, share your email ID.
Okay. Just here present, and then more options. There is a chat box, sir, right? Okay. Messaging maybe I can put here. Okay.
From chat box.
Okay. I will put it here. Gmail.com. Subrina@gmail.com. Thank you all. Thank you. Oh. Yes. Sir, please send me the screenshot after this ending of the session, the chat screenshot, so that I can collect the information. And if someone needs something, I'll respond. Of course. Okay, sir. Thank you, sir. May I leave now, sir? Yes, thank you. Bye. Have a great day. Bye.
Allah Hafiz.
Allah Hafiz. Assalamu alaikum.
Wa alaikum assalam.